Assalamu alaikum, everyone, and good evening, wherever you are. Welcome to our first Young Leader Forum for 2022. Our webinar tonight is going to be about adrenal disorders. Before starting our webinar, I would like to thank our sponsor for tonight, Serbia, for their continuous support to our Young Leader Forum activities. Before starting our webinar, would like to announce a few announcements regarding the webinar tonight. The webinar is live streamed on ADS YouTube channel. The webinar also will be available on demand on the ADS Institute website. We're going to have 3 lectures, then followed by Q&A sessions. So don't forget to type in your questions in the Q&A box and mention the speakers to whom you want to address the question to. If you're having any difficulties during the webinar tonight, there is a live support chat available in WhatsApp during the event, and you just text them and they would help you solving your problem. Finally, our webinar tonight is accredited by MOHAB. Up to 1.5 CME hours is going to be accredited for the webinar. And by the end of the presentations, complete the evaluations of the webinar, and after 3 weeks of the webinar, you're going to receive the CME. So our webinar will start with the first speaker. Dr. Badour Al-Amadi is going to speak to us today about the overview of congenital adrenal hyperplasia and the new treatment on the horizon. Dr. Badour Al-Amadi is a consultant endocrinologist at Dubai Hospital. She is completed the Saudi fellowships in endocrine and diabetes at King Faisal Specialist Hospital and Research Center, Riyadh, KSA. She is ECNO certified and completed UK specialty certificate in endocrine and diabetes. Dr. Badour, the mic is yours. Feel free to share your presentation, and we look forward for the presentation.
Good evening, everybody, and thank you, Dr. Asma, for your kind introduction. So my talk tonight is overview of congenital adrenal hyperplasia secondary to 21-hydroxylase enzyme deficiency and what's the new treatment on the horizon. So these are my objectives for tonight: some definition and pathophysiology, incidence of CH, phenotypes, the prenatal treatment for CH, how to diagnose, standard management of classical CH and how to monitor the therapy. Then we'll move to management of non-classical CAH and how to manage during pregnancy, then TART management, and finally the new pharmacotherapy. These are some of the abbreviations that you'll be seeing me using it during my presentation. So CH is a group of autosomal recessive disorder characterized by impaired cortisol synthesis. So if we move to this chart, the deficiency of the enzymes will affect those 2 horizontal pathways where the progesterone should be converted to finally aldosterone and the 17-hydroxy converted to cortisol. So there is deficiency in the aldosterone and cortisol at variable levels. This will lead to the activation of the ACTH, so the vertical pathway of the steroidogenesis will be activated, and there will be build up of adrenal androgens and build up of the cortisol precursor, that's the 11-deoxycortisol. The incidence of CH in most studies is between 1 in every 14 to 18,000, and in UAE it's 1 in every 9,000. If you go by haplotype study, the prevalence is even higher for the non-classical forms. That's the 1 in every 500 to 1,000, and if there is a consanguineous marriages, the prevalence goes 10-fold higher. The phenotypes of the CH, most of you know it, the classic salt wasting that's diagnosed in infancy, and that's the most severe form, and they have both cortisol and aldosterone deficiency. In the classic, but the non-salt wasting, that's the virilizing diagnosed in infancy with ambiguous genitalia, they have aldosterone sometimes sufficient, sometimes subclinical deficiency, and the cortisol are low with elevated androgens. The mildest form, that's the non-classic, and it's evident during the adolescence periods where there is a peak in the androgen release. If we go to the classification by genotypes, it depends on the residual enzyme activity and can be divided into four categories. The genotype null and A is the most severely affected, B and C are the less severely affected. So in classic, there is this classic salt wasting, there's 0 residual enzyme activity. In simple virilizing, there is 1 to 2%, and this 1 to 2% is enough to make enough sufficient level of aldosterone most of the time. In the non-classic, 30 to 50% of the in residual enzyme activity, and that's why you have reasonable levels of aldosterone and cortisol. Now, when we come to dealing with the CAH, secondary to 21-hydroxylase deficiency, two major problems when treating such population. One, the adrenal insufficiency that can be addressed by the mineralocorticoid and glucocorticoid replacement doses. The second issue is the androgen excess. Most of the time, you need to suppress the androgen excess by the use of supraphysiological doses of glucocorticoid, not only supraphysiological, but even against the normal circadian rhythm. The adrenal insufficiency, as you know, it causes life-threatening crisis. The androgen excess at neonate causes ambiguous genitalia. During adolescence, it causes abnormal growth, and that's why they end up with short stature if not treated properly, and can trigger sometimes precocious puberty. In adulthood, cause virilizations and infertility in both genders. Okay, let's start from the prenatal treatment of CAH. That's by dexamethasone. Now, the goal with treatment of dexamethasone, it acts locally by reducing the chance of female virilizations, so thereby reduce the social stigma that associated with this, reduce the need for reconstructive surgery and the emotional toll that results in the parents from an ambiguous genitalia. But you have to know that it will not eliminate for the lifelong glucocorticoid therapy. Now, whom we should or to consider using the dexamethasone, it's in women who had a previous child with CAH and now pregnant via the same partner if they did not go for the PGD, that's pre-genetic diagnosis and implantation. When to start the DEXA treatment, if planned to be started, should start very early because the genitalia start development and virilization by 6 weeks. So if you wait by 10 to 12 weeks to go for definitive diagnosis by coronary villus sampling, you are very late by that time, and already the genitalia is virilized. And use DEXA only when the maternal blood proves to be that the fetus is male rather than female, because the androgens do not interfere with the male genitalia development. So why only DEXA? Because it's inactivated by, it's not inactivated by the placental 11 beta HSD. The rest of steroids gets deactivated, so do not reach the fetus. What's the dose? The dose is 20 mics per kg per day of pre-pregnancy weight to a max of 1.5 per day. Now let's go to the clinical evidence behind the efficacy of DEXA. Here in a New York study where they studied 63 female fetuses, 15 with the use of DEXA had normal female genitalia and few had virilizations. In a French study, again, 12 had normal and few had moderate virilization. So it is effective in reducing the virilizations. And it's thought that the others who had variable degree of virilization, could be because of maternal poor compliance to DEXA, that's very common, and the treatment has been started late. Now let's go to the legal big societies. What do they recommend? Endo Society do not recommend and consider DEXA as still regarded as experimental therapy, only to be done in institutions where the protocol is reviewed abroad and you have a large number of patients, so you can determine the risk and benefit. Other societies like Sweden, they deseed the treatment because of possible adverse effects, as well German, American Journal of Obstetrics, because they all placed a higher value to prevent the adverse effects on fetus and mother from DEXA. They put it more higher value than the emotional toll that can result from atypical genitalia. How to diagnose? Diagnosis, when we speak about diagnosis, we are speaking about the post-infancy period. So if you use the morning 17-hydroxy, preferably in the follicular phase, less than 6 nanomole, if your hospital uses the international unit, it's excluded. More than 30 is included. Anywhere between 60 to 30, you need the synectin test. So if less than 30 is excluded. If we go into more details about the diagnosis, usually in classic, the level is high, above 30, it's in 200. You don't need any stimulation because it's markedly elevated. In non-classic, if you suspect your patient have non-classic CH, I would advise you to go for the synectin test because the basal morning 17-hydroxy is not as sensitive or specific as the synectin test. You can do it and then you miss the diagnosis because the 17-hydroxy would be normal. Usually, after whether 30 or 60 minutes of the synectin test, the 17-hydroxy would range anywhere between 30 to 60 nanomole per liter, and to diagnosis usually more than 45. So why I'm placing this range? Because anywhere between 30 to 45, it could be non-classic, but it could be heterozygous carrier or homozygous carrier. So if you're in doubt when it is in this range, you have to go for genetic analysis. One important point that sometimes even with the synectin test, it's less than 30, but because it's a heterozygous carrier. So now let's move to the treatment of classic congenital CAH. So the treatment composed, as all of you know, that of glucocorticoid and mineralocorticoid. Some points need to be mentioned that in growing adults, avoid the use of oral hydrocortisone suspension, and the reason that it will be unequally distributed within the suspension, so it's not recommended. Avoid the long-acting steroids because it hampers the skeletal growth. In adults, mineralocorticoid plus minus, and the reason that when they grow older, the aldose secretions increase, the mineralocorticoid receptors expand, and with the nature of the adult diet, it's high in salt. That's why they might not require for the mineralocorticoid. If we go to the standard doses for the glucocorticoid, when we're speaking about glucocorticoid, most of the time we're speaking about the immediate release hydrocortisone. It's max 15. Usually, if you exceed 15, the adverse event starts. And it's a thrice regimen. The perfect regimen is thrice regimen. For adults, for adults, it's 15. Usually ranges between 15 to 25. If you are using prednisone, up to 7.5. Now, stress dosing. What's the difference between stress and maintenance? In maintenance, it's a thrice daily regimen. However, in stress, it's a Q6 hours, so 4 times. In severe illnesses, however, mental, emotional stress, do not need stress dose. And these are the suggested stress doses for the glucocorticoid during crisis. Infants 25 per dose, kids 50, adults 100 per dose. Let's spend some time on this table. This is the biochemical monitoring for the CH. So in monitoring the CH, we monitor the glucocorticoid replacement, mineralocorticoid, and we look for signs of virilization. So for glucocorticoids, we monitor sodium, potassium, and plasma renin, and we aim for a normal. Now, just let me tell you that the renin is much more sensitive to evaluate eovolemia or hypovolemia as compared to sodium. So your target is low to normal. If it was high, it means your florinef dose is suboptimal, and you should increase it. And this, with increasing florinef, it will help you to taper down the glucocorticoid dose. For androgen markers, you look for testosterone and the androstenedione, and you target to near normal. Now, for 17-hydroxy, you never target normal, because otherwise you'll be over-treating. And I received in the past questions like, what's the target then for the 17-hydroxy? It's roughly below 40 nanomole per liter, and this is equivalent to 2 to 3 times of the upper limit. When we are following the adult population, in men, sometimes the presence of TART that we'll speak later, that's the testicular adrenal rest tissues, it releases a massive amount of adrenal androgens, and this will cause gonadal axis shutdown. So men have low morning testosterone and suppressed gonadotropins. And if you do the ratio of androstenedione to testosterone, normal eogonadal men, you have to achieve less than 0.5. If more than 2, it predicts infertility and and of course semen analysis. For females who are contemplating pregnancy, we aim for a progesterone level at follicular phase less than 2 nanomole. Usually to achieve this to help in pregnancy, most of females will require an extra dose of steroids at bedtime like prednisone. Is there other ways to follow? There are published reports about urine metabolites. PT stands for pregnaniterol. It's a metabolite of 17-hydroxy. KS is a metabolite of androgens. Despite its wide spread and clinical use, few supporting data whether those normalization of those would indicate good treatment or no. So generally, the American Academy of Pediatric think that those metabolites, urine metabolites, are unnecessary. Saliva, if your hospital provides, yes, you can monitor by saliva the same markers. The reason why we can follow that saliva, 1% saliva is derived from the plasma. People with poor dental hygiene and regular bleeding, they're not suitable for this test. Now let's move to the treatment of non-classic CH, and we start with kids. When do you need to consider treatment with glucocorticoid? Two things: premature adrenarche and advanced skeletal maturation. So what do I mean by skeletal maturation? Is the bone aging, advanced bone age. The premature adrenarche is the puberty, early puberty, where the onset of pubic hair is early, and other signs that you will see the phallus growth is becoming like adult size, oily skin, hirsutism, acne, those of adolescents. And in someone who have been previously treated non-classical and they have reached their adult height and their symptoms are controlled, always consider DCing the therapy non-classic. It's not a lifelong in non-classic. You don't need to keep the patient lifelong. If we go to males, adult males, most of the time it's not indicated. However, in few situations like infertility because sometimes of TARTs, adrenal tumors, phenotypes where you cannot differentiate, are you dealing with classic or non-classic? Yes, you consider. In females who are asymptomatic, not pregnant, no need. For females who are having hyperandrogenism or infertility, you can consider glucocorticoid. And if a female with non-classic became pregnant and she was not in glucocorticoid, you do not need to start a glucocorticoid during her pregnancy. Now, during the pregnancy, whether classic or non-classic CH, they have been on steroid, you have to continue it. And just bear in your mind that starting from week 24, the requirements might increase. And labor and delivery is a stressful situation, so you have to give the stress dose, and they have to speak to their obstetrician regarding the mode of delivery because of the previous vaginal surgeries and cephalopelvic disproportion, so might be C-section better for them. So what about the use of stress dose hydrocortisone in non-classic? Do we need in stressful situations? Yes, if the synaptic response to the test was below 4 to 500. Now let's move to TART. TART stands for testicular adrenal rest tumor. It's an ectopic tissue that is pathologically and biochemically similar to the adrenal cortex. The term testicular came because most of the time these ectopic tissues are located within the testis. However, you can find it in other places like pelvis, retroperitoneum, celiac plexus, anywhere. How to evaluate? Simply by MRI and ultrasound. Both are very sensitive. In MRI, in T1, it's iso-intense, T2, it's hypo-intense, and it diffusely pick up the contrast. Ultrasound is also more available, it's practical and less expensive and more studied than the MRI. Usually, it can diagnose even a small, tiny millimeter of TARTs, and hypervascularity is common in TART. How to monitor in adolescents? It's recommended to do the radiological follow-up annually. In adulthood, like every 2 to 3 years. And anyone who have TART, always offer the male the option of sperm banking. Now, this article is about TART, published in Endocrine Review. It's an excellent review, published in 2019. The prevalence of TART is very variable, and it increases with age after 8 or 10 years. And since it increased with age, the adult prevalence of TART is higher than the kids' prevalence of TART. Is there a correlation between TART and severity of CH? It has been found that TART is more prevalent in severely affected cases and less prevalent than the severely affected. Some studies did not find correlation between TART and CAH severity. It's thought probably because those studies had small sample size and maybe low statistical power. This is how TART looks like. Ultrasound, hypoechoic lesion within the testis. This is within the MRI. You can see it's a large lesion. Now, how to differentiate TART from Leydig cell tumor? It's difficult. Now, let's have a look at this table. In terms of pathology, both look same. In terms of radiologically, both have same features. However, a TART usually bilateral, and Leydig cell tumor is unilateral. And with the intensified glucocorticoid treatment, TART may respond. Leydig cell tumor do not. Now, why it's important to know? Because TART is treated with steroid, and Leydig is with surgical, because 10% of cases can be malignant. TART have stages that has been suggested by Klashen and his colleagues. In stage 1, there is hypertrophy of the cells. Here you can see the cells become hyperplastic, and here it becomes multilobulated. In stage 4, they start to form the peritubular fibrosis. In stage 5, where it is irreversible, there is diffuse peritubular fibrosis and diffuse hyalinization. The stage is irreversible and infertility occurs. Treatment is with optimizations with the glucocorticoid. If the TART is small, just use standard dose of Dexan. If the TART is big and there's fertility issue, then you go up with a higher dose. You can know this, that is causing infertility. As I said before, when you look at the ratio of andro to testosterone, it's more than 2, predicts infertility. Offer patient sperm banking. If the intensified treatment did not help, go for sperm extraction, and consider testicular biopsy just not to miss other diagnosis. So TART is managed medically. Only indication for surgery is suspicious of carcinoma or severe tenderness. There are some published case reports about use of mitoten, which is chemical adrenalectomy in TART, and HCG with FSH for 2 years with patient with TART and hypogonadism, and it was successful. Now, there are cohort studies where they studied to remove the TART surgically and sparing the testis, and this resulted in failure. There was no biochemical improvement, neither fertility improvement, because of the irreversible damage. So finally, I would say for TART, there are no methods to prevent its development. There are no guidelines to treat to guide how to treat patients with TART. It's only from published case series, reports, cohort studies. Now let's move to the final part of the presentation. That's what's the new horizons of the treatment of the CAH. So since 1960s, after the glucocorticoid discovery, there has been very little innovation in management of CAH. And despite the available medications, they tend to be patients obese, metabolic complications, still shorter than their colleagues, poor quality of life, poor fertility, and this led to the companies to the development of the new pharmacotherapies. This article has had a very excellent review of the clinical advances, the recent clinical advances in the pharmacotherapy of CAH, published in European Journal of Endocrine recently. So if we go by categories, the medications that are in trials, the CRF receptor stands for corticotropin releasing factor receptor blocker. There are 2 medications in clinical trial, the crinecerfont and the tidacerfont. There's the glucocorticoid replacement. There's the discovery of the new modified release glucocorticoid. There's the hydrocortisone pump, the cortisone granules, and there's the steroid enzyme blocker, that's the CYP17 inhibitors, the abiraterone. There's the androgen receptor blocker, the flutamide. So let's start with the first one, the CRH receptor blocker. And this is called the blocker replacement regimens, where you block the CRH that triggers the ACTH, and the ACTH that triggers the release of the adrenal androgens. And you with these medications in the clinical trials, they were able to cut down the supraphysiological dose of glucocorticoid to a physiological dose. So there are 2 types of CRF receptors. One is in the pituitary and 2 is the peripheral tissues. These medications work on the CRF receptor 1. So let's go to the outcome of these clinical trials. You can see for both, there is a significant drop in both the 17-hydroxy and the androstenedione, ranging between 20 to 40 in the crinecerfont group, as well as the other medication. So, and they were, in this clinical trial, they were able to cut down the glucocorticoid dose. Now, in kids, until 2018, the lowest available dose of immediate standard treatment, that's the immediate release hydrocortisone, is 5 mg, and it can be scored into half, and this is licensed. Now, for neonate, this is not enough, so people used to dissolve it in water. The problem with dissolving that it does not dissolve well in water and gets stick to the plastic material of the syringe. So thanks to the hydrocortisone discovery of hydrocortisone granules, where they were able to provide the tiny doses that is suitable for infants. Now, the other way of the new approach is that they targeted the circadian glucocorticoid. How is that? Now, if we go to physiology, the ACTH start to rise overnight after midnight from 2 a.m. and peaks in the early morning between 5 to 8 a.m. in the morning. And this peak in CAH is exaggerated and accompanied by the rise in the adrenal androgens. So so here, where is the most the peak of the disease occurs in the early morning. So to address this, they either said you give in a reverse circadian rhythm, that's instead of giving the normally the highest dose in the morning, you give at bedtime, or you give a long acting at bedtime, because so that the steroids continue to work during the midnight where the rise occurs. Because even with the immediate release glucocorticoid, when you give at bedtime, it does not continue until the morning, or the infusion of hydrocortisone, or the new discovery of the modified release. So the bedtime dosing was good. It had a good reduction in the markers. However, the downside of this, that when you give a higher dose at bedtime, this is the time when the complication starts, and DEXA has been associated, because it's given at bedtime in such scenarios, been associated with no BMD. The other circadian rhythm treatment is the infusion, that they are mimicking the 24-hour release. And with this treatment in the clinical trial in 6 patients, it was successful, improved the quality, and in people who had very high levels of androgens, it restored the period and reduced the size of the TART. Now, the negative outcome, that it's pump malfunction and it can result in skin infection. Still not approved, this therapy. There is a case report published in a young boy, who they used the hydrocortisone infusion because he was having increased clearance of the hydrocortisone, and he used to have very high levels of androgen markers. So when they gave the infusion, and it went down dramatically, and over 4 years he maintained suppression of the adrenal androgens and maintained normal growth through puberty. The modified release, the pilandrine, is available in Europe, but it's used for licensed for adrenal insufficiency. Studied in CAH, it provides good control of daytime. However, because there is no the night or the early morning, it was not successful. The other modified release, chronocort. By the way, when we say modified release, it means the outer layer has the immediate release and the inner layer has the sustained release. So in chronocort, they give BID. It had good control of daytime, nighttime, and the early morning peak. So this study about the novel chronocort therapy, and it's approved now in Europe and great. Every hospital should have this treatment now. You can see, when compared to the standard dose, how beautiful the chronocort maintained the level of 17-hydroxy lower compared to the standard with no peaks, and even the androstenedione. And even when they went to beyond 6 months, 1.5 years in the extension study, the efficacy maintained. Now let's go to the adrenal targeted therapy. So we target the enzymes of the adrenal directly, the adrenal gland. One of them is the abiraterone. So the abiraterone is a medication that blocks the 17-hydroxylase, so the end result blocks the sex hormones. It's used in prostate cancer that are castration resistant, so it blocks all the androgen that triggers the disease metastasis. So it has been used in tried in cases with CAH for 2 months and showed very good biochemical reduction. So when they used the abiraterone, they were able again to lower the dose to physiological dose. It could be considered in future to be used in prepubertal kids, because here you need to lower the glucocorticoid to allow for the normal growth velocity. And in childbearing age, it's quite, if they're not using OCPs, there is risk of fetal teratogenicity. The mitotane, so mitotane is known to endocrine, or that is a chemical adrenolytic medication used for treatment of Cushing disease. It has been tried in CAH, and I'll show you the case report for this male who had classic CAH with a large TART, and he was infertile. So when they gave the mitotane, you can see how sharply the 17-hydroxy and the androstenedione went down throughout the 2 years of its use. This was accompanied by this raise in the CRH. This raise of CRH, you think maybe it will expand the TART size. However, no, the TART volume even went down, and the gonadal suppression that was from the high androgen release of TART that was suppressed, it went back to normal, and the sperm count went back to normal, and fertility and paternity was achieved in this male. If we go now to the adrenal targeted therapy, but surgical. Endo Society do not recommend it to be used, and the argument is the risk of surgery, anesthesia, irreversible, and maybe activation of the adrenal rest. So let's review the science behind the adrenalectomy in young kids. Published case series of 15 kids. Their glucocorticoid dose went lower, and the androgen signs even improved. However, some of them developed adrenal crisis, some developed severe hypoglycemia, and some who were initially post-operative required a small dose of steroid. Later, with follow-up, the precursors, the androgen markers went up, and the dose of glucocorticoid went back again higher. And this thought maybe because of activation of TART, because of the raise in the ACTH that occurs post-operatively. And in females, they tried for females who had desired fertility. It was successful outcome. Again, some of them experienced adrenal crisis and significant pigmentations. All of them experienced significant pigmentation. So the initial enthusiasm for adrenalectomy was hampered later by the long-term complications, and avoid using this method, especially for people who are poorly compliant to medication prior to surgery. Another modality that has been tested in clinical trials is using the androgen blocker. They used the combo medication that have triple medications, reduced dose of hydrocortisone, plus flutamide, that's androgen receptor blocker, plus testolactone, that's aromatase inhibitors. And in this study, where they studied in 28 kids and they used this treatment, with this treatment, surprisingly, all the androgen markers in 17-hydroxy went up. However, despite the raise in the biochemical markers, they achieved better growth and normal bone maturation. Growth hormone and GnRH analog, yes, you can use them. It has been studied, and also improves the adult the height. And Endo Society do suggest to use them if you are having CH with judicious use of glucocorticoid and mineralocorticoid, and still you think you did not achieve good height, as below minus 2.5 standard deviation. So yes, you can consider this treatment. Now, my last few slides is about the preclinical development, and these are animal studies ongoing, like monoclonal antibodies against ACTH, ACTH receptor blocker, gene and cell-based therapy. If gene and cell-based therapy were successful, it's going to be really novel treatment, because you don't even need the physiological doses of the glucocorticoid. It has been used in, the trial is still ongoing, in mice where they used the adenoviral vector that is encoded with the deficient gene, that's the 21, and injected into the mice that has the CAH, and the mice temporarily has had reversed the steroidogenesis for almost like 44 days. The study is still ongoing. So if this way of therapy proven to be to maintain its long-term efficacy, it's really novel treatments. Now, finally, I would say that Endocrine Society, they advise against the use of any experimental therapy if it's outside for formally approved clinical trial. So don't get yourself into legalities. If your hospital do not run a formally approved clinical trial, do not give these experimental medications. This was my last slide, and thank you for listening.
Thank you, Dr. Budur. That was informative. Just a reminder to all attendees, please write down your questions in the Q&A box, and we'll discuss all the questions during the Q&A sessions. We're moving now to our second lecture, and our second speaker for tonight is Dr. Araya Al-Mazroui. She's going to talk today about the approach to a pheochromocytoma case. Dr. Araya is a consultant endocrinologist at Tuam Hospital. She is adjunct assistant professor at CMHS, UAE University. She completed her fellowship training in diabetes and endocrinology at Imperial College Healthcare NHS Trust, London, UK. She is also a graduate of Harvard Medical School, Global Clinical Scholars Research Training. And Dr. Araya is very well known for her extensive involvement in academic teaching for under and postgraduate. Dr. Araya, the floor is yours. Please feel free to share your presentations, and we're here listening to you.
Thank you so much for the kind introduction, and thanks for giving me the chance to participate in today's activity. So hopefully I will go through approach to pheochromocytoma through one of the cases that I have encountered in the clinic. So during this presentation, hopefully we will try to cover the following outlines, including epidemiology, presentation, diagnosis, genetics, and preoperative management, as well as post-surgical follow-up. So to start with the case, this is a 73-year-old female who was referred to endocrine clinic for further investigation of a possible pheochromocytoma. And this was incidentally discovered as a right adrenal mass in CTKUB that was down for abdominal pain that was thought to be due to renal stone. She reported no symptoms of muscle cramps or weakness or cushingoid features, and there were no paroxysmal symptoms of palpitation, sweating, or headache. Also, she did not report any weight loss or cachexia or B symptoms, and she is not known to have any extra-adrenal malignancy. Her past medical history was significant for having stage 4 chronic kidney disease and bilateral renal cysts, which were reported as large, and uncontrolled hypertension on multiple medication. Also, she was newly diagnosed with diabetes type 2 on linagliptin, and she also had hyperlipidemia on dowel therapy. She has a remarkable family history, and her physical examination showed elevated blood pressure with a pulse rate of 60 and a BMI of 20, and the rest of examination was unremarkable. So to start with, what is pheochromocytoma paraganglioma, or in abbreviation PBGL? These are a neuroendocrine tumor that originate from a neural crest tissue. And when they come or originate from the adrenals, we call them pheochromocytoma. And when they originate outside the adrenal, we call them extra-adrenal paraganglioma. If they are from parasympathetic ones, then they are usually in the head and neck, and most of the time they are unsecretory. While when they are sympathetic, usually from the paraganglioma below the diaphragm, that's mean the abdomen and pelvis, and usually they are secretory. The genetic predisposition plays very important role in BBGL since it is considered the most commonly tumor that have hereditary background in human. In terms of epidemiology, still it's considered a rare tumors with an incidence of around 8 cases per million per year. However, the number of cases have doubled over the last decade compared to the previous decades. And also the prevalence depends on what cohort of patients you are studying. So if the prevalence is up to 7% in patients with adrenal incidentuloma, however, it is much less in study that involved autopsy. And it's more common in children with hypertension of around 1.7% compared to adults with hypertension. This is one of the population-based study in Denmark, and also there have been other studies showing the same, that there is an increase in the incidence of pheochromocytoma and sympathetic paraganglioma over the last decade compared to previous decades. And in this study, as you can see, that apart from the increased incidence, specifically this incidence was mainly in patients who are above age 75 or in the group of 50 to 75. And this is because of the increased number of CT imaging and increased detection of incidentuloma and workup of incidentuloma for pheochromocytoma. And also because of the increased testing with genetics and doing surveillance for patients who are harboring genetic mutation. In terms of the presenting symptoms, this is one of the old study which was multicentric in Italy, where they described the symptoms of these patients. And many of these patients, they were presenting with paroxysmal symptoms individually, like one symptoms or a couple of symptoms, like palpitation, headache, or sweating, in up to more than 60% of the cases. However, only around 15.5% of the patient will have the classic triad that we usually are taught of. So minority of patients will present really with palpitation, headache, sweating altogether. And since this is a very, it covers a very old era, there was a high percentage of patients who were presenting with hypertensive crisis. Still, there is almost 20% of patients who had normal blood pressure. In terms of the clinical presentation, there is several factors that can define this. One of these factors is the biochemical phenotypes. So patients who are harboring tumors that produce mainly noradrenergic, they are likely to have sustained hypertension. However, if the catecholamine type that is secreted is adrenergic, they may end up having paroxysmal hypertension. And if it is dopamine secretion, then they could be asymptomatic or hypotension. Apart from the biochemical phenotype or the type of the catecholamine that is secreted, also the concentration of that catecholamine is important, because dopamine, noradrenaline, and adrenaline exert what we call it dose-dependent effect on the systemic vascular resistance based on their affinity to the receptors, beta and alpha adrenergic receptors. So for example, you can see in case of dopamine, when it is in low concentration, it actually will cause hypotension and decrease the systemic vascular resistance because of a higher affinity to dopamine. While in high concentration, it will have a more affinity or further affinity to alpha receptor and will cause hypertension. Similarly, adrenaline do. However, noradrenaline, irrespective of its concentration, will lead to elevated blood pressure with the increased systemic vascular resistance. Also, the risk of hypertensive crisis is depending or can be partly explained by the catecholamine profile, where the risk of hypertensive crisis is more with noradrenaline secretion in pheochromocytoma. This phenotype or this clinical phenotype recently have been studied in the recent decades. And it seems that the modern pheochromocytoma really presentation is quite different based on the method of discovery. So because now many pheochromocytoma cases are or paraganglioma are detected and discovered based on incidental findings or based on genetic case detection, we can see that those with genetic case detection are younger compared to those who are discovered based on symptoms or incidental finding. Also, the tumor size on those who have genetic case detection is tumor size is much smaller compared to the one with the symptoms and incidence. And there is good correlation between the solid part of the tumor and the amount of a plasma metanephrine secreted. And the larger the tumor, the larger amount of metanephrines that could be seen. And therefore, you could see that those patients who undergo surveillance due to background genetic mutation, they have a less amount of plasma metanephrine secreted. And even they have a lower or a higher percentage of non-functioning tumors and a lower number of average symptoms compared to those who are discovered based on symptoms or incidental finding. Also, over the time, the method of detection of pheochromocytoma have changed a lot. And this is one study, this is Mayo Clinic data, but it has been also replicated in other centers. And you can see clearly that in the past, the most common way to detect or discover pheochromocytoma were based on symptoms, because these are the patients who were screened for pheochromocytoma. However, over the recent last decade, most of the patients who are diagnosed with the pheochromocytoma are basically diagnosed upon workup of incidental findings of adrenal mass or paraganglioma. And also there is increased number of patients who are diagnosed based on surveillance for those who are harboring a genetic mutation, and less commonly based on symptoms. Also, the number of cases that have been discovered over the last decade is much more than previous decades. And this is because also for the same reason, more incidentalomas are worked up due to this more imaging that are done. So the next question is really whom we should screen for PPGL. And we used to screen, and we still screen patients who have symptoms of PPGL, either spontaneous or provoked by the use of medication. You can screen those who have cardiovascular events with signs and symptoms that are indicative of PPGL. Adrenal incidentoloma, whether they have hypertension or not, if the density is above 10 Hounsfield unit, any carrier of germline mutation that could predispose to PPGL, or any syndromic features that are suggesting genetically determined or syndromic PPGL, and the previous history or family history of PPGL. This table lists some of the commonly used medication that can trigger pheochromocytoma crisis, including antiemetics, metoclopramide, commonly used beta blockers like propranolol, and opioids, as well as steroid. So to summarize this part, the presentation of PPGL or the incidence have increased, which likely reflects the changing mood of discovery of these tumors. Now, the spectrum of indication for biochemical testing includes not only signs and symptoms, but also workup of adrenal masses and also periodic surveillance of those with the genetic background. Also, the prevalence of PPGL in patients presenting with adrenal incidentoloma or a mutation of tumor susceptibility genes are relatively high compared to patients presenting with signs and symptoms alone. Back to the case, so the patient had the full workup for adrenal incidentoloma, and you could see that she had elevated plasma-free metanephrines, which were more than twofold upper limit. And you can see also here hemoglobin A1C that time was 6.6. So talking about the secretory pattern of PPGL, in pheochromocytoma, almost 50% they will have a mixture of nor-epi and epinephrine secretion. Almost 50 will have only nor-epi. Occasionally, some patients may have both norepinephrine and dopamine. In paraganglioma, mostly they will produce only nor-epi. Very rarely that they will produce any significant amount of epinephrine, and the reason is because they lack the enzyme BNMT that convert nor-epi to epi. Other may produce both combination of nor-epi and dopamine, and some may have only exclusively dopamine secretion. So what to measure? Before we discuss this, there is some terminology that we have to be clear about. When we speak about free catecholamines, then we are speaking about nor-epi and epi. When we speak about free metanephrines, then they are free normetanephrines and metanephrines. When we speak about conjugated one, then they are the sulfated form. The total metanephrine include both the free metanephrines and the conjugated form. The recommended screening test for BBGL is the plasma-free or urinary metanephrines. And the method of measurement is liquid chromatography mass spectrometry. There is some evidence suggesting the superiority of a plasma over the urinary test, and this basically comes from this multi-centric prospective European study where they involved more than 200 BBGL cases, and they screened patients based either on sign and symptoms or based on hereditary risk of BBGL or incidentaloma finding or personal history of BBGL. All these patients had measurement of both plasma and urinary metanephrines after being fasting overnight and lying supine for at least 3 minutes. And what they found is that the sensitivity of both tests is quite good with good specificity. However, the plasma-free metanephrines were doing slightly better than the urinary metanephrines, 96 compared to 92%. However, when they subclassified them according to the pretest probability of having BBGL, then the plasma metanephrines did better when the patient is at high pretest probability. When they have low pretest probability, both of them were doing very well. In this study, they defined low pretest probability, that's mean a patient who have been screened based on sign and symptoms, while high pretest probability when the patient is screened based on incidentaloma or hereditary risk of BBGL. So there are other single center study that found there is no difference between really a plasma or urinary metanephrines. When we speak about the methodology, we say LCMS. However, you need to know that LC can be done with different detection methods. One of them is mass spectrometry, and another commonly used is electrochemical detection method. And you need to know which method your labs is using, because electrochemical detection method is predisposed to what we call it analytic interference. And this is where, for example, acetaminophen or beta blocker can interfere and leads to false positive result. However, irrespective of what analytic methods you use, whether mass spectrometry or electrochemical detection method, they are both prone to pharmacodynamic interference, because this is unrelated to the assay. This is related to the drugs that cause really elevation of the catecholamines due to blockage or of the reuptake and so on, like antidepressant, phenoxybenzamine, monoamine oxidase inhibitor, sympathomimetics, and levodopa. Also, it is very important to have pre-analytic sample conditions correct. So as you can see in this chart or in this figure, that the diagnostic yield or the positive predictive value and negative predictive value of the metanephrines are much better when the patient is in supine position. And you should use the same reference interval for that position. So make sure that the patient is lying supine at least 20 minutes before they take the blood. So on bottom line, we could say that in high-risk patient with BBGL, we could use plasma over the urinary. In low risk, it doesn't make difference, you use plasma or urinary. This is provided an accurate method of measurement is used and appropriately established reference interval and strict adherence to the pre-analytical precaution of supine rest. So now, in summary for this part, measurement of a plasma-free or urinary metanephrines are the recommended screening test. The method is LCMS, and maybe there is a slight superiority of a plasma over urinary. You supine position for at least 20 minutes before taking the blood, and there is no dietary precaution necessary. But if you are measuring plasma 3-methotrexamine, which is the metabolites for dopamine, there will be a need for overnight fast. In high suspicion for PBGL, elevation of even one metabolite more than twofold is highly suspicious for PBGL. Otherwise, elevation of 2 or more, then also this is highly suspicious. There is a good correlation between the magnitude of a plasma metanephrine elevation and the tumor burden and the prognosis within the patient himself, so intra-patient comparison. And biochemical should always precede imaging, except in emergency cases. So back to the case. So we know this patient have elevation in her metanephrines, and we have this CTKUB that was done initially, and based on that, they discovered the lesion. And this is, of course, CTKUB, so it is non-contrast. And you can see the lesion here is around 5 by 3.1 centimeter. It is homogeneous, no necrosis, no calcification, and the left adrenal was normal. And you can see both sides, these large renal cysts that she has. And this baseline non-contrast Hounsfield unit is elevated around 64. Then she had also MIBG, which proved that there is an uptake in this lesion, and this is confirming pheochromocytoma. So what are the imaging we use in this patient? We have two types of imaging, anatomic imaging and functional imaging. To start with the anatomic imaging, pheochromocytoma can present as homogeneous or heterogeneous lesion. And because they are highly vascular tumor, they are prone to internal bleeding or hemorrhage and necrosis. And as you can see in this here, where there's a central necrosis. Sometimes they may appear very ugly tumors that they mimic adenocorticoid carcinoma, where there is heterogeneity, cystic formation, and even calcification. Also, around 33% of pheo can be presented as a cyst, and this is called cystic pheochromocytoma, where they will have a rim that enhanced with contrast. And usually, in these cases, the magnitude of elevation and metanephrines would correlate with the solid part of the tumor. Second point to know is that almost all patients with pheochromocytoma, they will have an enhanced attenuation Hounsfield unit above 10 in CT. And therefore, if you have a patient or a lesion that with a Hounsfield unit less than 10, you are 99.5% that it is not pheo. This is provided that the measurement was taken correctly. Number 3, the contrast washout is unreliable in these cases because many of these patients will have a high washout similar to adenoma. And in fact, in the previous study, the almost third of these patients were having a high washout similar to the adenoma. And this is one of the cases that show that where this patient have an enhanced Hounsfield unit above 10, venous very high, and then when you calculate the absolute washout was more than 60 and the relative washout more than 40, similar to the adenoma. So this is unreliable method to use in pheochromocytoma. Another way to differentiate is there is possibly a rule for the venous phase CT enhancement. In this study, they found that patients with pheochromocytoma have a very high venous phase Hounsfield unit compared to the adenoma. And using the cut of 85, almost 88% of pheochromocytoma cases were having a venous Hounsfield unit above this level, while only 16% of adenoma cases. However, this has to be taken with caution because it will be difficult to take the appropriate reading in patients who are presenting with heterogeneous mass or where there's calcification or where there is cystic or central necrosis and only rim enhancement. So this may require likely a homogeneous tumor or a good solid part to take the readings. In MRI, in T1, there will be a reduction in the signal intensity during out of phase compared to in phase, as you can see here. And in T2, there will be a bright intensity, or what they call it light bulb, which can be found almost also in the third of cases of pheochromocytoma. So it is, both of them are non-specific really. Though I'm not talking about paragangliomas, but it's also very important to look for them, because when you do the imaging for adrenal, you have to look through also the para-aortic area, especially the Zucker-Kandel body, where you will find many sympathetic paragangliomas there that could be responsible for the patient's symptoms. So you can see here, these are at the peri-aortic region, common findings of abdominal paragangliomas, also in the mediastinum, posterior and anterior. So like this patient who have been operated without knowing that he had a paraganglioma. And in fact, it was non-secretory in a patient who have succinate dehydrogenase B mutation. Also, it is commonly to find around carotid bodies and a glomus and in the head and neck area, where it causes compression symptoms. And this is also in succinate dehydrogenase C patient. Sometimes also it can be found behind the urinary bladder, and this is the pelvis one, and usually also they are symptomatic. So after the anatomical imaging, the functional imaging. Functional imaging do play an important role in the management of pheochromocytoma and paraganglioma, and they usually have sensitivity and specificity subtype based on the subtypes of pheo and paraganglioma. And here in this picture, you can see the different ligands and their receptors. Usually the indication is for evaluation of metastatic disease, and these are the predictors or patients who could have a metastatic potential, including patients who have succinate dehydrogenase B mutation, who have large tumor above 5 centimeter, extra adrenal location, or more adrenergic biochemical phenotype, or high methotrexamine level. Also, you could look or evaluate for recurrence and multifocality or restaging, or for performance of surveillance screening. And also to select patient for the proper theranostic application, for example, gallium dotate scan for this patient to decide to give them lutetium dotate in case of metastatic BBGL, or MIBG 123 in case MIBG therapy is indicated. This is a table from the Society of Nuclear Medicine European, where they suggest the type of nuclear imaging to be done based on the underlying hereditary or genetic mutation. So in case of sporadic pheo, the first choice is really FDUBA or MIBG. Second choice is gallium somatostatin analog. In case, for example, with patient with extra adrenal sympathetic or multifocal or metastatic, somatostatin analog as the first choice, second choice FDG and FDUBA. In case, for example, of inherited pheo, apart from succinate dehydrogenase B, like for example, neurofibromatosis or MEN or VHL, the first choice is FDUBA, second is MIBG and gallium somatostatin study. So this is another algorithm showing the same, but in different configuration. So the practical tips in imaging for pheochromocytoma screening with elevated metanephrines, anatomical imaging may be usually insufficient. You may need to do the nuclear imaging in selected cases, but if a patient have low risk of metastatic disease, epinephrine secreting that is less than 3 to 5 centimeters, then you don't need to do it. And the choice of the radionucleotide imaging is based really on the underlying germline or somatic mutation. Back to the case. So the patient already have now pheochromocytoma with biochemical workup and imaging workup. And she was referred to genetic, but still we don't have her results. In terms of genetics, as we highlighted before, they are the most commonly inherited tumors in human. and 80% of BBGL can be explained by genetic alteration, almost 30% as germline, the rest as somatic. Lack of family history does not preclude the presence of germline mutation, and the discovery of susceptibility gene actually led to better understanding of the clinical and imaging phenotype. And the preferred technique is a next generation sequence, and therefore you may end up having lots of variant of unknown significance that need complementary testing to establish pathogenicity, and you need to work very close with the genetist. This is different genetic background with different mechanism of action. So the most commonly prescribed driver mutation are what called cluster pseudohypoxia, Wnt signaling, and kinase signaling. If we go to the pseudohypoxia, for example, these succinate dehydrogenase subunits are belonging to a Krebs cycle. And you can see that most of these tumors either adrenal or extra-adrenal, abdomen, pelvis, and head and neck. However, you know from this figure that they are carry the highest risk of metastatic disease and the least differentiation. When you go this way to the kinase signaling, neurofibromatosis, RET, and so on, then they are likely to be adrenal, or uncommonly to be abdomen or below the below diaphragm, sometimes not or not occurring in the head and neck, and they are having less risk of metastatic disease and more differentiation. This is another way to show that. For example, in cluster 1, succinate dehydrogenase B, they are usually also secretory. So this genetic background can define to you the biochemical and which imaging to use. So succinate dehydrogenase, for example, they are usually normetanephrine or methoxyteramine secretory. The imaging of choice is gallium dotted scan, tumor location mostly extra-adrenal. The risk of metastasis is high to intermediate and in young patient. For example, cluster 2 kinase signaling, they are usually normetanephrine or metanephrine or metanephrine alone. If DUBA is the best choice, adrenal is the most common location, and the metastatic risk is low. And here, if we go individual to genetic mutation, for example, in succinate dehydrogenase B, subunits, you can see that the B is the highly tumor associated with metastatic potential. It can present in most of the patient as adrenal or as extra-adrenal tumor. While, for example, C and D and AF2 mostly as head and neck tumor. Also, VHL and neurofibromatosis, NETs, all of them are mostly as adrenal tumors. It is also worth to mention that succinate dehydrogenase D and AF2 are also autosomal dominant like the others, but with maternal imprinting. So is it important to do genetic testing in all patients? Yes, it's important. You can see that having a genetic mutation patient with BBGL is more likely when the patient is diagnosed at young age. However, still, even if the patient diagnosed in their 60 or 70, you can see that up to 20% of the cases diagnosed at this age group are having or harboring underlying genetic mutation. So genetic testing for germline mutation is indicated for all patients, and if you have tumor material, you can run also somatic tumor mutation analysis. So now this patient should be prepared for surgery. So we block here with alpha blocker using doxycycline and beta blocker, intensify antihypertensive, high sodium diet, targeting her seated blood pressure below 130/80 with a systolic above 90 and heart rate between 60 and 70, upright 70 to 80. She had laparoscopic adrenalectomy, which showed right adenofuchromocytoma 5x4x2 centimeter. And post-operatively, her repeated metanephrines were normalized. Her blood pressure is much better and less amount of antihypertensive, and she is off hyperglycemic medication. So preoperative management or preoperative mortality has dropped significantly from around 40 to 3%. And this is because of the optimization of pre-surgical treatment with antihypertensive drugs, mainly alpha blocker, because of better surgical and anesthesia technique, and because of early diagnosis of these patients as adrenal incident trauma and carrier screening. So tumors that are less, in size, they are much less than before. The goal really of pre-surgical management is to prevent anesthesia and surgery-induced catecholamine storm and its consequence, to relieve the symptom and control the blood pressure and prevent cardiovascular complication before and during surgery. And the oral medication that we use mainly is alpha blocker. The most commonly used are the phenoxybenzamine and doxycycline. Phenoxybenzamine is non-selective, non-competitive, and it is usually associated with alpha blocker, with reflex tachycardia and nasal stuffing. You start with one dose and you gradually titrate the dose. If the patient could not tolerate higher dose or start to develop side effect, then you can add another antihypertensive in form of calcium channel blocker to reach the targets. In terms of the beta blocker to be used, mainly metoprolol, propranolol, or atenolol. And we use them when the patient starts to develop tachycardia with a heart rate supine above 80 or heart rate upright above 100. Also, you have to instruct the patient to take high sodium diet, and this is in order to restore the intravascular volume depletion and prevent pre and post-operative hypotension, and also orthostatic hypotension. Before surgery 24 hours, to give saline in order also to avoid hypotension. This is the only trial that compare the two kinds of alpha blockers head to head. And in this study, two groups of patients, one were on doxycycline and the other group in phenoxybenzamine, and they were titrated and treated the same till reaching the target. The primary outcome of this study was the cumulative time of a blood pressure value outside the target range during BPGL surgery, and there was no difference between the two medications. However, in secondary analysis, looking for what is for hemodynamic instability using a specific score, there was more intraoperative hemodynamic instability with doxycycline and a higher need for vasodilator drugs. However, there is no difference in the primary outcome and no difference in the side effect profile. Also, the preoperative complications was very low, and this is expected with all the advancement, not only on alpha blocker, but as we said before, in surgery and anesthesia and technique and so on. What is the optimal pre-surgical blood pressure and heart rate targets? As we have mentioned before, seated blood pressure target less than 130/80, upright systolic blood pressure above 90, heart rate target between 60 and 70 in seated position, and 70 to 80 in upright position. These targets are based on retrospective trials and expert opinion. There is no randomized trial to compare two targets and to find which is the right target. Surgery, usually minimally invasive, is the preferred approach, and either in transabdominal laparoscopic or retroperitoneal adrenalectomy, which are most commonly performed. And the minimally invasive is associated with a lower blood loss and shorter post-operative length. In multicentric study, the conversion from laparoscopic to open was only in 7.7%. And the open adrenalectomy could be the primary surgical approach in selected cases where there is large tumor, suspected local invasion, or paragangliomas. And adrenal cortex sparing surgery could be considered in hereditary form of BPGL like VHL and RET. However, this is in order to avoid steroid dependence, but this is they may have a higher rate of recurrence compared, of course, to bilateral adrenalectomy. Post-operatively, you need to measure the blood pressure or to monitor the blood pressure at least 24 to 48 hours. And the risk of post-operative hypotension was equal in both types of alpha blocker in the prescribed study. If any happen, IV fluid or vasoactive agents can be used as depicted in this table. Hypoglycemia could happen also, at least should be monitored, blood glucose should be monitored for at least 24 hours and to be treated with IV dextrose. And in cases of unanticipated adrenal insufficiency, IV hydrocortisone. But for those patients who are going for bilateral adrenalectomy, this have to be planned and anticipated. For post-surgical follow-up, you need to repeat the catecholaminomethanephrines, free methanephrines, 2 to 6 weeks after to ensure adequate resection. And thereafter, the patient needs to be followed symptomatically, biochemically, plus minus imaging. It depends on the genetic background. If it is a sporadic, then at least you need to follow up the patient annually for 10 years. But if the patient is young and or with the genetic background or with a larger tumor, then they need a lifelong follow-up.
Dr. Raya, time is up.
2 slides more. In terms of patients who are harboring germline mutation, there are many concepts that can be found online freely that are used for surveillance of these patients. So in conclusion, increased incidence of PPGL likely reflects the change of mode of discovery of these tumors, and measurement of a plasma or urinary free metanephrines are the most accurate test to detect or exclude PPGL, and nearly all pheochromocytoma have an enhanced attenuation on CT above 10 Hounsfield unit, and functional imaging is essential in patients with high risk of recurrence or multifocal disease, and all patients with PPGL should be considered for genetic testing. A pre-surgical medical preparation is mandatory with alpha blocker, and minimally invasive adrenalectomy is the preferred surgical approach. All patients operated for PPGL should be followed up annually at least for 10 years, otherwise lifelong. Patients at high risk, as we said, can be monitored or should be monitored and followed lifelong. With that, I finish my presentation. Thanks for listening.
Thank you, Dr. Araya. That was an extensive review of pheochromocytoma, and it was an interesting case. So just a reminder for everyone, please place your questions in the Q&A box, and we're going to discuss it during the Q&A sessions. We're moving to our third speaker for tonight, Mr. Bakhit Bishtawi. He's going to talk today about avoiding potential predatory journals. Mr. Bakhit is a specialist librarian at Medical Library, Dubai Health Authority. His team is responsible for managing and developing all the library electronic collections, services, and training. Editorial Administrator, Editorial Office, Dubai Medical Journal. Mr. Bakhit, you can share your slides and the mic is yours.
Okay, thank you, Dr. Asma, for the introduction. Let me start my screen. Can I ask if the screen is there and you can hear me well?
Yes, Mr. Bakhit, we can hear you, and you already shared your slides.
Thank you very much, and thank you you all for joining this session. Today we'll talk about how to avoid actually predatory journals. My name is Bakhit Bishtawi. I'm working in the Dubai Health Authority. This is my email, my library website, my WhatsApp. I am a little bit available more in WhatsApp if you want to communicate with me. First of all, if any name, publisher, author, journal, editor, country mentioned here in this session, it's only for learning purposes. Apologize in advance. Hopefully by the end of this session, you will be able to differentiate actually between predatory and reputable journals, learn some skills to avoid publishing in predatory journals, as well to help you where to go and seek guidance and help if you want to publish your paper. The name predatory, actually, there is more than one name you might find, but the most used one is predatory, maybe faked, hijacked, hoax, pseudo, sham, unethical, untransferred, dark, bogus, etc., etc. Maybe you have other names you can share with me later, for example. And usually we talk about predatory journal and predatory publisher. Both looks the same because usually a publisher publish a journal. Simply, the goal of a predatory journal or a predatory publisher is they have the same goal: wrongly harming or using others for profits. Arabic, إيذاء الآخرين أو استغلالهم لتحقيق أرباح. They are available there looks like publishers, looks like good journals. They don't care about the quality of the work. There is no peer review. They false claims or promise like boosting impact factor, indexing in major databases, engaging unethical business practices, fail to follow accepted standards in best practice scholarly publishing. As a definition, you can simply find they are within such practices. Usually they are looks legitimate, but they are not. They are doing their work without checking articles for quality. They are doing their work without providing proper editorial services, without formal peer review, without providing proper publishing services, using quick publication, using business model, pay to publish. Imagine, you pay, then we will publish. Using false or misleading information. And sometimes, by the way, they are aggressive in practice, and they try to scare you. Sometimes you ask them, hey, please, I want to withdraw. They don't agree on that and start sending you emails asking for fees, money, etc., etc. Let's have some figures and statistics. In 2014, by the way, there is more than 8,000 predatory journals. Imagine, 996 publishers. Around 500,000 articles published. In 2019, the number is also increased. They are more than 60% from Asia authors affected from this practice. 18% from Western countries, 16% from Africa, and 6% from others. Imagine. In a study published this year from this Inter-Academy Partnership, AIP, at least 25% of respondents to their study have either published in a predatory journal, participated in a predatory conference, or maybe they don't know. And by the way, all my statistics here, you can find a link where you can get more details. And another study actually indicated that 60% of articles published in predatory journals attracted no citation. This statistic in 2017 published in this paper that a sample of 1,907 papers in more than 200 supposed predatory journals, they found that India is the most country in predatory journals. You can see Egypt and Nigeria from lower countries. Iran, Turkey, China from middle income countries, and we have UK, Italy, Japan, and United States from higher income. Actually, United States, they have predatory journals, but the authors there are not much affected. This statistic or this figure from Google, Google Trends, usually they publish from time to time graphs like this about terms used or terms used in search. Look here that predatory journals, this red color dot, till 2011, there was maybe zero search about predatory journals, but from 2011, you can see the curve goes up, trending. People start asking about what's a predatory journal, why predatory journal, and so on. So simply, the term predatory journal is a little bit new. We can say that it's started from 2010. Here I have around maybe 15 characteristics, different characteristics about predatory journals and predatory publisher. And usually if you want to know if this journal is predatory or not, you can find always, or you can see always, that they have a poor maintained website, like such this website on the left side. The publisher usually use email like Gmail, Yahoo. Look at this one, for example. The corporate offices are in this location in New Delhi, and they are using this Gmail. They have another office in the United States. They have another office in United Arab Emirates. They have an office in Iraq. They have an office in Canada. So this publisher have 4 offices, different places, and at the end they have Gmail account. So whenever you see a Gmail, Yahoo, Hotmail account for a journal, there will be a question mark. The publisher usually, they don't have something named ISSN. This is very important. And the DOI. There is no ISSN or DOI with that publisher. It means maybe or potentially it is a publisher. It's a predatory publisher. Another example, sometimes the publisher uses names like network, center, association, institute, academy, society. Look at this one. Research and Scientific Innovation Society. In fact, there is no society in this name available there. So when you find such terms with a name with a publisher, you should think that maybe this is a predatory fake publisher. The publisher sometimes posts non-related or non-academic advertisement, like this one, for example. The publisher falsely claims one or more of the journal have actual impact factor. And this is the most trick the publisher used, impact factor. When you see the impact factor, think 10 times before you publish with that journal. And today we will learn how to differentiate between the correct fact impact factor or with the false or faked impact factor. Sometimes you will see the publisher mention such logos, WordCat, ESGI, ICMGE, Google Scholar, etc., etc. This looks really fake and it's not correct. The publishers sometimes include links to legitimate conferences, associations, universities. At the bottom of the website, you will see Washington University or MBRU University or any university, but in fact, there is no links between the publisher and that university. The publisher displays statements that they promise quick acceptance. This is totally not accepted in publishing. The publisher claims to be a leading publisher. The publisher cannot judge, the publisher should not judge themselves. The publisher should bring judgment or from others, from other associations. Here, this is when you see the publisher have hundreds of journals, and all the journals are started with Asian American Accounting Research, Asian American Aerospace, Asian American Agriculture, Asian American Advanced, and so on. 100. With this publisher, I think they have 200. You see, Asian American Clinical Cancer, Asian American. I don't know how they can manage such journals, but in fact, they are fake. They are predatory publisher. The publisher claim non-profit, although they are a for-profit company. The publisher owner is identified as the editor. Yeah, this is important. The editor and the publisher are the same. A publisher website does not identify a physical address. Okay, all what they use is just fill the form, and we will come back to you. The journal has no editorial board, or sometimes the journal listed scholars as members of editorial board. Some journals, by the way, look, this journal, they have 493 editors. Oh my God, how they can manage 493 editors from Italy, from United States, Greece, China, Ecuador, I don't know. So when you see that the editorial board is huge number and different countries, this might be a predatory journal. The journal have only form. If you want to communicate with them, your name, email, subject, message sent, and you don't know where is this message is going. There is no system, there is no reference number, nothing there. The journal sends many invitations for you and asking you, you are number one, you are the professor, you are the scientific man, you are the best physician, publish with us. When you see such messages, it seems that it's coming from predatory journal. Sometimes even you will see the messages have some typo mistakes. Manuscripts are requested to be submitted via email. Any publisher, any journal asking you to submit by email a manuscript, figures, graphs, tables, x-rays, 99% predatory. Okay, nowadays all journals are using systems. There should be a system. You create your account, you have your own profile, everything is there. But sending manuscripts via email, it means predatory. They are also sometimes, you see, call for papers, send via email, Microsoft Word, send to Gmail. When you see such things, it means predatory. Okay, the journal provides an impact factor, IF, although the journal is new. No journal can get an impact factor before 3 years. This is ABC. Not only that, the journal has impact factor, IF, although it's not available in Web of Science. What's Web of Science? Web of Science is the only association provide impact factor. If a journal said they have impact factor and they are not registered with Web of Science, 100% they are fake. Because the only association worldwide whom provide impact factor is Web of Science. So look at this example. Quarterly, there is ISSN, nice name, DOI, indexed here, indexed there, but the impact factor 0.182. When I search for the journal, it's not available in Web of Science. It means fake, predatory. This is another example. Okay. No, the same example, the biochemistry and biotechnology. When I search for it in Web of Science, there is no results. So, and they said we have impact factor. So this is fake or predatory journal. The journal is not included in Midline, in Web of Science, in Google Scholar, in the OEG, Embase, Scopus. This is an indicator. It means that the journal may be predatory. The journal falsely claims indexing in well-known databases like Scopus, DOG, JCR. Look at this example. No one of these impact factors for this journal is available in Web of Science. There is fake index like Copernicus value, systematic impact value, site factor. All are fake index and fake impact factor. So, for example, this journal, they have index Copernicus value, ICV. It's not legitimate. This Cosmos impact factor. For you, you might not concentrate on Cosmos and you will take impact factor. Then you said, oh, wow, this is good journal. Also, this is a predatory. Another one is SJIF impact factor. This company, this organization, SJIF, they are not providing impact factor. So they will, it's a matter of cheating you, and you thought this journal has impact factor 5.157, although it's not. Another example. This journal, they have this impact factor. I searched in Web of Science, it's not there. They have something H index, I-10 index. There is nothing for the journal H index. H index is for the author. If a journal said we have H index, this is big mistake, this is big cheating. There is no H index with the journal. The H index is for the author. Provide insufficient information or hides information about fees. Okay, see here, we have the most inexpensive article processing fees. It's not like this. Our current APCs are by far the lowest. No journal will say that we are highest or lowest or middle or economic or whatever. The self-published model is free of charge. This has no meaning. It is cheating. Offering to publish an author's paper or later sending an unanticipated surprise invoices. At the beginning, they will not mention anything regarding fees. And after a week, they said, hey, congratulations, your paper is accepted. Now you need to pay. And sometimes you can see an icon like this in the website of the journal, pay here or pay now. The journal charges submission or handling fees instead of publication fees. The journal offers options for researchers. Wow, prepay, imagine, prepay plans. Like you can make, for example, plans for mobile or something. Prepay plans, membership, enable. When you saw such things in any website for any journal, it means predatory. Institutional prepay, individual prepay. This is also fake predatory journal practice, wrong one. Here, article submission 0, fast track 0, article publication 400. What does this mean? This is fake and predatory practice journal. If you don't have funds to pay such fees, you will have an opportunity to waive each fee. We don't want fees to prevent the publication of worthy work. All these sentences are fake and predatory practices. The journal gives unrealistic promises regarding the speed. They will tell you, send us today, tomorrow we will publish. The journal's peer review process is minimal or none. Submitted 23rd of February, revised 24th, accepted 25th, published 26th, 23, 24, 25, 26. This is not, let us say, correct peer review. Journal revised February 9, accepted February 15, published February 25th. The journal does not describe copyright agreements. The journal is not asking for manuscript statements. This is very important. They are not asking you for ethical approval. They are not asking for patient consent. They are not asking for conflict of interest. They are not asking for funding sources, data availability, author contributions. They are not asking for these things. If you find a journal not asking for such statements, they are asking only for manuscript, figures, tables. This means predatory journal. No withdrawal or not responding to author requests. You want to withdraw, they are not responding at all. They are not asking or replying to you. The journal is associated with a predatory conference. By the way, there is also predatory conferences. The journal falsely claims universities or organizations as partners. The journal using terms like international. By the way, in a study, 80% of the journals with the name international, global, it means predatory. Asian American accounting. Another example for international. Yeah, always when there is international, you should think twice. They are mimicking the name. See this example. International Journal of Medicine. This is a true journal. International Journal of Medical Sciences, also true. What they did, International Journal of Medicine and of Medical Sciences. So they took part from this journal and part from this journal with the International Journal, and they add the word research fake. For example, you published in the International Journal of Medicine, so still in your mind, the International Journal of Medicine, a nice quality, high quality journal. Then when you read International Journal of Medicine, suddenly you thought that this is true, although this is not true. Another example, International Journal of Biological Sciences, true. International Journal of Biology and Biotechnology, true. Then the publisher has a journal, International Journal of Biology and Biotechnology. So they took parts from here, and this is a fake journal. The journal used misleading metrics, like instead of ISI, they use SIS. ISI is a correct organization, but they said they use SIS. Also, site factor instead of site score. Site score is from Scopus, and we know Scopus is a legitimate index, and Scopus provides site score. So the fake journal, they use site factor. It's a misleading term, like the one here. ISI, Institute of Scientific Information, Web of Science is correct. Then they write SIS, like this one, SIS. This is fake. Cosmos impact factor. Here, for example, this author, they said they are in compliance with Elsevier. Although COPE guidelines, it's published by Elsevier. So they'll put the name Elsevier here so as a misleading information for you to thought that this journal belongs or in compliance with Elsevier. Because we know Elsevier is a well-known publisher. Yeah, operate from a Western country, utilizing a BO books from a Western country. That's why many predatory journals coming from Europe and America, while actually operating from a developing country, like this one. It's New Delhi, India, and they have an office in America, an office in United Arab Emirates, and an office in Canada. Use offices located in Eastern country while actually operating from development country, the other way. The journal have a contact us only, contact us, name, email, that's all. The journal has DOI, but the articles, they don't. The journal have asked to stop sending email, but they are not stopping. Email received from a journal do not include the option to unsubscribe. 5 practices of reputable journals. Good journals actually have a peer review process. Reputable journals have an editorial board. They follow recognized publishing standards, and they are transparent about fees, and they are indexed. These are the 5, let us say, points how we can know that this journal is a good one, and they are following the COPE and the ICNGE recommendations. These are the 2 most well-known codes used in the publishing era. Resources, tools to identify predatory journals. The first one is the international registers, the ISSN, the DOI. But if you find the journal has ISSN, it doesn't mean it's legitimate. Might be predatory, because they register themselves here, then they practice fake. They register themselves with the digital object identifier, then they practice fake. But it's an indicator. Another most important part is the Web of Science. If you want to know the impact factor is correct or not, search for the journal in Web of Science. If the journal in Web of Science, it means the impact factor is correct. This is a very good indicator, okay? If it is in PubMed, 95%, the mark, because 5% or maybe less, 2 to 3% of predatory journals leaked into PubMed by mistake. Scopus, Embase, the DOIG directory, Google Scholar, Think, Check, and Submit. So all these databases and lists is a good start to help you figure out if this journal is legitimate or predatory. We have a list, Bale's list, and this is done with this librarian long time, 2011, updated 2017, and now continued to 2019. You can click on the list and you will find thousands of journals there listed as predatory with publishers. Tables is a new list, but this is subscription wise. Here, this is a nice work by Beals, how to stop predatory journals. What is the harm caused by predatory publishing? Predatory and low quality journals corrupt the literature. Imagine millions of papers scattered there in the literature. Medical sciences, by the way, the most science affected by predatory publishing. Medical science is affected widely by journals publishing on scientific medicine. Publishing without peer review let poor academics, clinicians have a chance to get promotion and job. You know that sometimes you need to publish a paper so as you will get promotion or even a job. So publishing with such predatory journals will give the chance for maybe others. It can actually hurt academics, clinicians, the chances of earning promotion and jobs, because when you publish in a British journal, then the promotion committee figure out or find out that this paper is published in a British, they might tell you sorry. So it's both sides. Waste of efforts, money, and time, as it doesn't add any scientific merits to authors. Damage the reputation of institutions and funding agencies. Sometimes, for example, Al Jalila Foundation, they give a researcher, or sometimes happened in Dubai Health Authority, they give a grant or ask a resident to make a research, and after 1 year of work, hard work, the paper published in a British journal. Spread of ordinary or even worthless papers and errors, their website might not stable. And this is, by the way, another important point. You publish today, after a year, you want to find your paper, it's not there, disappear, because they are there sometimes temporary. 1 year, 2 years, 3 years, collect money and disappear. Affect the author H index, and this is very important for professors in academic institution, university. H index is very important for them. So H index usually calculated by total number of citation. If your paper is published in a British journal, it means that no citation, and your author, your H index as an author will go down or not grow up. See this example. How nice the name, Annals, British Medical. So it looks very nice name, okay? And they have ISSN. They have 2 years impact factor. They are in InfoBase index, Cosmos, and they are using the CCA license, creative license agreement. So what do you think? Do you think this is fake, predatory, or good journals? They are using even authenticate for plagiarism. What I did actually, I searched for the ISSN in the ISSN portal, and it's there, good. Then I searched for the impact factor. Impact factor, remember, impact factor means Web of Science. So I went for Web of Science. This is the website of the Web of Science, and it's not there, no results. Simply, this is a fake impact factor. Simply, the whole journal is predatory. Bye-bye. It's not available also in PubMed. Okay, so this is one way, or this is an example. Okay, good, we're about to finish. Do you find it difficult to discover potential predatory journals and publishers? Are you in doubt with your journal selection and seeking help? Maybe you already selected a journal, but still not submitted. Good. And you are seeking guidance. But maybe your journal is already submitted, but still not published. Here you have a chance. Or your paper is already published and seeking guidance. If you are in one of these stages, okay, and you want help from Dubai Health Authority Library, we are willing to help you by just filling this form. And actually, we will keep your request confidential. Even you can fill it without giving us your name, maybe only your email. And we will answer you, or we will reply to you within 1 to 3 working days confidentially. You can now, by the way, using your mobile, just point your camera. Okay, I might ask the organizer, Cheryl or Dr. Asma, if you can send this link and this code to all the participants later after the session. And we are willing, actually, in Dubai Health Authority, Dubai Medical, the Medical Library Unit Research Section, to help you in figure out if your paper is published in a correct journal or predatory, if you are in a, even Dr. Asma, if you can send the whole page, okay, and also you can share it with any colleague, because we believe that fighting those predatory publishers and journals is a must. Again, I'll wait for 1 minute more. You all at this, please, you can just point your mobile and click on the link. You will be able to use it. Not only now, you can save the link for later. You can see that your name is optional, your title is optional, but your email, what can we do, is a must, because I want to reply to you. If you don't want to use your email, you can use fake email, and then you can give me your WhatsApp. I will reply to your WhatsApp. In a study, by the way, internally, we found more than 26% of the authors around us are affected by this. This is a long list of articles. You can maybe use it as later on further reading. I can allow Dr. Asma Cheryl to share my slides later after converted to PDF. Together, we can stop predatory journals and publishers. Thank you very much for listening.
Thank you, Mr. Bakhit, for this presentation. And for the sake of time, we're going to have a quick Q&A sessions. Please, all the speakers, can you unmute yourself and appear on videos? And I'll start with the first question to Dr. Badur. There is a question from Nisreen Al-Fari about a case she's having. She's saying that I have a girl with the congenital adrenal hyperplasia and growth hormone deficiencies with absent carpal bones. If there is any association, she's asking if there is any association. According to her, she didn't find any correlation in text or online. What is your thought about this case?
Okay, that's very interesting questions. Now, for the growth hormone, when I presented the growth hormone, it's not because they have those patients have underlying growth hormone deficiency. It's only because the glucocorticoids suppress the growth velocity, and the high androgens result in early epiphyseal closure. So they end up by being short. And that's why if you think they are very short, you can help them with the growth hormone. But not to my knowledge, there is association between congenital adrenal hyperplasia and growth hormone deficiency. Now, regarding the second part of the questions, that the absent carpal bones, again, I haven't seen anything in the literature, but there is a published case report of CH in a young adolescent with absent carpal bone syndrome. It's something new in the literature, and it was found to have, this guy, he was found to have a vanishing bone syndrome. That's called Gorham disease. It's an osteolytic bone disease of pediatric and adolescent age. So that's why they published this case reports. It's new, unique association. So Dr. Nasreen, I would strongly encourage you to, if you're having this combined syndrome, to publish it as a case report, because this is something very unique. And if your hospital facility where you work provides chromosomal mapping, this would be great.
Thank you, Dr. Badur. Question to Dr. Raya from Dr. Asha. She's asking, as an internist, when should we screen for FEO, especially that classical presentation only in 15% of patients? And we encounter at the practice many CKD patients with uncontrolled blood pressure on 3 medications and more. So what is your input in this?
This is a good question. First of all, when we mention 15 to 20% in recent cohorts, or around 30%, we meant by the triad. So the presence of the triad paroxysmal symptoms. However, more than 60% of the patient, they may have 1 or 2 symptoms of the paroxysmal symptoms. Number one, remember, pheochromocytoma is very rare. This is number one. Hypertension is very common. So hypertension per se is not a specific sign or symptoms for pheochromocytoma. If you will screen, you have to screen really very selected patients with uncontrolled hypertension on multiple medication, young, with incident trauma, and so on. Number two, having paroxysmal symptoms, even if the patient report 1 or 2 of paroxysmal symptoms, initially from history, you need to look for alternatives and basic workup, for example, hyperthyroidism or anxiety. All these are overlap. They have symptoms that overlap with the pheochromocytoma. So, I mean, don't jump immediately to think of the rare things. First, try to exclude the most common things. Number three, having uncontrolled hypertension in CKD is something common. You need to seek help also from your nephrologist to select the proper medications for the patient before jumping and screen for pheochromocytoma. And point number four, there is some studies that try to create a reference range for patients of CKD for metanephrines. So there is a specific studies that went for that. I did not highlight them. So in brief, yes, you may think about it, but try to exclude the common things first. And remember, hypertension and uncontrolled hypertension is more common than pheochromocytoma. So to avoid widespread screening unnecessarily.
Thank you, Dr. Raya. Mr. Bakhit, question. Most of the physicians are really eager to publish, and let's say that one of the physicians receiving an email from one of these predatory journals. Tell us in very simple practical steps, how should we deal with such emails?
Sure, thank you. First of all, nowadays, I think our culture become better than before dealing with emails, with websites. We start to believe that any email is correct one. So we need to think twice before answering such email. You need to look at the website of that email. You need to look at the email, the domain linked to that email. Anyway, so the best way, number one, is to read it wisely, to ask a colleague to come for example, if your library support you with such service like the one we have in the YLF Authority, which actually we can help any author in the region, we don't mind. So again, you should search, ask, go there till you find that this email is coming from a legitimate publisher or journal, not from a predatory one.
Thank you, Mr. Bakhit. Another quick question to Dr. Abdur. What are the risks associated with dexamethasone use in the prenatal?
With the dexamethasone, okay. Now, I mentioned in my slides, many of the societies, they are against the use of the DEXA. The literature behind why DEXA is not recommended because of the maternal fetal adverse event that can happen. In maternal, usually it's because of the excess glucocorticoids, because DEXA is 20 mics per kg per day. It's a quite high dose. So the weight gain, the stria, the hypertension, the gestational, though they are modest and manageable, many times females decline the DEXA treatment in subsequent pregnancies because of these things and mood swings. In terms of the for the fetal, there is some of the reported possibly that could be linked to dexamethasone, that when they compared with DEXA, the orofacial defects prevalence was higher in the group of people who used the DEXA as compared to none. There are a few published case reports of acute encephalopathy, and in animal studies, there was some problem with pancreas and liver cell reprogramming. That's why, because of still not, because of the possible teratogenicity and the long-term impact of these, they decided to not to put it as a let's say, official recommendation that to be used until further studies confirm its safety or safety profile.
Thank you, Dr. Budul. Actually, there's a couple of questions about the neonatal screening at birth and the use of medication during the prenatal and diagnosis of CAH in women. But for the sake of time, we don't have time. One more question to Dr. Raya. Question is, we noticed in your case that patient was diabetic and it was resolved after surgery. How few can cause hyperglycemia? What is the mechanism?
So alpha adrenergic stimulation can cause suppression of insulin secretion and increase glucagon secretion, which can lead to diabetes. So a patient with a few chromocytoma may have also diabetes. And therefore, once the tumor is resected, no more adrenaline, they are or catecholamines, they are prone to hypoglycemia post-operatively, and that's why you have to monitor them for at least 24 hours with blood glucose monitoring regularly in order to detect hypoglycemia.
Thank you so much, Dr. Araya, Dr. Badur, and Dr. Bakhit. It was very good sessions, and thank you all. So we'll move to our industrial meeting now. Our industrial meeting session is going to be about glycoside, MR effectiveness and safety in real world settings. Again, we're thanking Servier for sponsoring our webinar for tonight. And our speaker for tonight is going to be Dr. Antoine Arkea, who's going to give us the topic, lecture about glycoside, MR effectiveness and safety in real world settings. Dr. Antoine is a consultant endocrinologist, Imperial College London, Diabetes Center in Abu Dhabi, a former assistant professor of medicine at Towley University School of Medicine, New Orleans, USA, and he's American board certified. Dr. Antoine, the mic is yours, and feel free to share your presentation.
Thank you so much, Dr. Asma. Here we go. Okay, good evening, everyone. Thank you. Thanks very much for having me and to be able to join you this evening. Here we're going to be talking a little bit different topic, and we're going to make it short and simple just to make sure the message is really go through. So we'll be talking about glycoside MR effectiveness and safety in real world setting, the CPRD study, the Clinical Practice Research Data Link. First of all, the evidence-based medicine is not one factor. It's really multiple factors. They all can go together in order to come up with the conclusion. So the evidence-based medicine first factor is really the best evidence from research, obviously. And the other interlinking factor is the clinical expertise and experience. And thirdly is the patient perspective and input. What is the real-world data added value? So the real-world data is data that are collected outside the controlled constraints of conventional randomized clinical trials to evaluate and what's happening in the normal clinical practice. In randomized trials, the question is, can it work? But in the real-world data, does it really work? So this is really the balance between the dilemma between the randomized and the real-world data is really interesting the way it's described. So can it work? Does it work? So that's the question. The real-world effectiveness study comparing the glycoside MR versus sitagliptin. So this is an article study was published in August 2020 by Francesco Zaccardi. Is a comparative effectiveness of glycoside modified release versus sitagliptin as a second-line treatment after metformin monotherapy in a patient with uncontrolled type 2 diabetes. Very simple, straightforward, to the point. So the background about achieving the glycemic control in type 2 diabetes, we all know that lowering glucose remains a major focus of type 2 diabetes therapy. Type 2 diabetes guidelines recommend a glycemic goal to individual patients. We all know, and we're all familiar, it is HbA1c less than 7%, that's our target in most type 2 diabetic adult patients. Whereas now the goal is becoming more, more constrained and more strict about it in certain people, like in patients with early uncomplicated diabetes. If you can reach a goal of HbA1c of less than 6.5, this would be great. So for most patients for whom metformin alone is no longer sufficient, prescription of another agent is recommended. It could be a sulfonylurea or DPP-4 or even a GLT-2 inhibitor and so on. What about the glycoside modified release? So it allows a progressive release of the drug in once daily dose regimen with evidence of a lower risk of hypoglycemia compared with glimepiride. So it's really against what we always think that all sulfonylurea are the same and all sulfonylurea can cause or frequently hypoglycemia. So in this molecule, particularly, the hypoglycemia is not very common. Advanced trial has demonstrated that an intensive strategy based on glycoside MR to achieve mean HbA1c level of 6.5% improved microvascular outcome safely. Sitagliptin is most used at DPP-4 with good safety profile with minimal risk of hypoglycemia. No real-world studies comparing glycoside MR and DPP-4 inhibitor at this time. So the real-world study of glycoside versus sitagliptin, the aim was to compare the effectiveness and safety of glycoside MR to sitagliptin as a second-line type 2 diabetes mellitus treatment in a real-world patient population. So the primary outcome was time to achieve HbA1c level of less than 7%. The secondary outcomes, the time to HbA1c level of 6.5 or less, time to a reduction of HbA1c of 1 or more % from baseline. The third point was treatment duration as measured by both durability and persistence. And then fourthly, we're going to look at the hypoglycemia events. The Clinical Practice Research Data Link, the CPRD, collects de-identified patient data from a network of GP practices across the UK. Patient records from the CPRD Gold database, they were linked to the hospital episode statistics, admitted patient care HES APC, and the Office for National Statistics ONS death registration database were used to determine all patient characteristic and outcome data in this study. I don't want to bombard you with all these terminology and abbreviation, but just it's important to understand what really method were used to address this study. So there's something called the High Dimensional Propensity Score, HDPS, was used to match patients who initiated glycoside MR with those who initiated sitagliptin. New users of glycoside MR were matched to new users of sitagliptin with fixed ratio of 1:1. Durability and persistence were compared using the log rank test, and for hypoglycemia, they used the HES APC data. So the study design was a baseline period, and there was the index date that was in January 1st, 2010, and there was the observational study period time of more than 9 years until October 21st, 2019. So the main inclusion criteria was type 2 diabetes of older than 18 years, first line with metformin, HbA1c more than 7% in the 6 months before index date, 12 months of historical data prior to index date. The main exclusion criteria, obviously the type 1 is excluded, and the secondary diabetes such as gestational, neonatal, steroid-induced, insipidus, MODY, and so on. So this is the design of the study and the number of patients were really recruited. So initially they started off with 45,500 patients. About 35,000 they were excluded by study design. So they had about 10,000 left. There was about some 3,300 missing data. So the one who really fulfilled the inclusion criteria without missing data, they were about 6,686. And they were divided into two groups. 1,200 each, not each, in the glycoside MR, and 5,479 in the sitagliptin. And they use the 1:1 propensity match, and we end up having 993 patients each in the glycoside MR and the other group in sitagliptin. So we end up having this number of patients. The baseline characteristics, In general, about 58-59%, they were male. Average age is about 63. The mean HbA1c about 8.5. Body BMI was about 31%, and mean diabetes duration average about 4.4 years. The anticoagulant therapy and antiperspirant therapy and antiplatelet therapy and lipid-lowering therapy, they were just used in any diabetic patient that you might be on, as you may have some blood pressure medication, dyslipidemia, and so on. So the primary outcome is time to achieve the HbA1c of less than 7%, as we mentioned in the introductory slide. So the rapid separation of curves in favor of gliclazide and approximately about 3 months, there was some separation, and they were about 35% more likely to reach target of HbA1c of less than 7% with the gliclazide MR. So they have a high percentage of patients on the gliclazide to achieve the HbA1c of less than 7%. In the secondary outcome, the time to achieve HbA1c of less than 6.5%, again, here was able to show the rapid separation of curves in favor of gliclazide in the study. And about 51% more likely to reach target of HbA1c of less than 6.5% with gliclazide versus sitagliptin. Similar durability and persistence. Durability was really very much similar between sitagliptin and gliclazide MR. The persistence, again, was very similar between sitagliptin and gliclazide MR. What about hypoglycemia? You remember in the secondary endpoints, we were looking at the hypoglycemia events. So in the hypoglycemia events, the rate in per 1,000 patient year, there's about the total number of hypoglycemia event about 4.7 in the gliclazide MR versus 2.6 sitagliptin, which is expected because still gliclazide is a sulfonylurea. No matter what, the risk of hypoglycemia definitely is going to still be more than sitagliptin. But the actual absolute number, the rate of hypoglycemia is very negligible and is very low. We're not saying it does not exist, but is really not a worrisome percentage. Now, the number of events in the gliclazide MR, 3,201 patient year, about 15, and severe hypoglycemia event about 4, and there were less definitely in the sitagliptin group, 8 of total number of hypoglycemia event, and 1 in the severe hypoglycemia event in the sitagliptin group. So as I said, as I promised, it's going to be a short presentation just to give you the real comparison of gliclazide MR versus sitagliptin. So there was a well-designed real-world study from like 9 years. In this real-world study, gliclazide MR was more effective, a glucose-lowering drug than sitagliptin, with similar durability and persistence to treatment, as well as similar and low rate of hypoglycemia. So when you have a patient and you really are not uncontrolled on metformin and you are thinking of adding a second drug, gliclazide would be maybe a good choice. Still suffering, still being used. Well, definitely we're not just neglecting or not talking about the SGLT2 inhibitor nowadays, even ahead of DPP4 and so on. But the gliclazide MR is still a medicine that is really safe to use, effective, and available and cheap if cost is a concern. And I think I came to my last slide. I would like to thank you for having me with you to spend this few minutes. And thanks for Servier to allowing me to present this symposium in a short time. And thank you very much. And I'll be glad to take any question if there's any.
Thank you, Dr. Antoine, for this presentation. I have a couple of questions, and we know that the gliclazide MR is a single dose daily, but we still see in the practice that people dividing the dose to BD. What is your input on this?
Yes, definitely you can give it, it's designed to be given as full dose as once daily, as you mentioned. Is this correct? It comes in 60 milligram tablets, so you can give 2 tablets together, whether with lunch or with breakfast. But there are some people, as patients, that we might be concerned about taking 2 tablets together, and they know these kind of class may cause hypoglycemia. They feel, psychologically, I think they feel more at ease or safer to split the dose. But from a pharmacodynamic and pharmacokinetic point of view, there's no really difference. But if you do split it, that's fine. If you give them both together, that's even better. So really, from our practice, use the only time that I do sometimes split them just to make them safer. They feel safer and they feel happier, and that's the only reason. Otherwise, no. You were correct.
Gliclazide is a sulfonylurea, and you just mentioned the comparison between gliclazide and other class of medications in terms of hypoglycemia. How you compare gliclazide to other sulfonylurea in terms of hypoglycemia risk?
That's correct. Definitely, gliclazide MR hypoglycemia event is really much less than we see in other sulfonylurea that we use in daily life now. The other commonly used sulfonylurea that we use is glimepiride. Then we still have glibenclamide and other molecules, but as you all know, that the use of sulfonylurea has been decreasing for the last few years. So the last two pretty much used, especially in this part of the world, we use gliclazide and amyral. But I can tell you and assure you that definitely gliclazide has a much less hypoglycemic event compared to the other one like glimepiride. Even though glimepiride is a good medicine and is effective and we have a long experience. And by the way, in the United States, we don't have gliclazide. We have amyral, which is the glimepiride that we use. But I've been here now for 15 years, so I acquired really long experience using the gliclazide very safely.
To what extent GFR we can still use the gliclazide? Down to what level?
Yes, it's not as strict as in other medication that you used to remember when we talk about metformin. It used to be just any decrease in the GFR, and then we used to stop it. Now we use it, safely down to 60 and 30 and 45. So no, you can decrease the dose of metformin. The same thing that with SGLT2 inhibitor. Now we can really go down up to even 30 of GFR. It can still be used. In the sulfonylurea, you can go down even if it's like up to 30 GFR. You can still use it, but you have to monitor the dose and the response. So renal insufficiency is not a contraindication to use sulfonylurea, but you watch what you do and you take it from there. But 30 is the cut point. Yeah.
Thank you so much, Dr. Antoine.
Thank
you. It was a pleasure having you tonight. Thank you so much.
Thank you, Dr. Asma. Thank you very much.
Masala. Thank you, everyone, for attending our first webinar for the 2020 series of Young Leader Forums. For all those who are asking about the CME, so please, fill the evaluation form, which will be sent to your registered email to obtain your CME credit. CME will be available 3 weeks after the webinar. The webinar will be available on demand on EDS Institute website and the EDS YouTube channel. Please visit EDS websites for upcoming webinars, and you can have details about our upcoming events. And if you want to review our previous events, it's going to be recorded on the website. We'll do a few announcements. We're having a couple of events coming during the next couple of weeks. So the second Young Leader Forums, that's going to be about obesity and lipids. That's going to be on 22nd of June, inshallah, Wednesday. The same time, 7:30 to 9:35. Hopefully we're going to be on time the next time. And we're having also a couple of events under the EDS. So EDS Connect Thyroid Webinar Series is going to be also at the end of May. Thyroid Nodule 2, May 22nd, 26th. Then the thyroid and surgery is going to be June 9th. So we thank you all to join us during the next couple of events. And to know more about our events, you can just go to our www.edsinstitute.org and or www.emiratesdiabetes society.org, and you're going to know more about our upcoming events. Before ending our webinar tonight, again, I would like to thank Servier for sponsoring our event tonight. Thank you all for attending. We had more than 350 attendees tonight. Thank you all for attending this webinar, and we're waiting you in the next event, inshallah. Thank you all. Good night.